I want to thank you so much for inviting me. And I wish I could be there in person, but I am happy to be a very small part of the All India Ophthalmology meeting for 2021. I'm here to talk about my favorite techniques in pediatric cataract surgery for 2021. Now, first, in infants less than 7 months of age, my preferred and favorite technique is to make 2 paracentesis openings and use an irrigating cannula and the 25 gauge vitrector handpiece to remove the lens in these infants by performing an anterior vitrectorexis, lens aspiration, posterior vitrectorexis, and anterior vitrectomy without ever having to come out of the eye. 1 time in, 1 time out, and tenovicryl to close each of the paracentesis openings. And then I place a Silsoft silicone contact lens on at the end of the surgery. And this contact lens is powered based on a lens constant that Rupal Trivedi and I created for the Silsoft lens. No patch and shield, no subconjunctival medicines. And here's what this same child looked like 1 day post-op. I use aphakic spectacles in these children when the surgery is bilateral. Another favorite technique, these same infants at age 4 to 6 years of age, I go back to place my secondary intraocular lens, and almost always I can place these intraocular lenses in the capsular bag. I open the Sommering ring. When you do surgery very early in life, there is new cortex formation that creates a Sommering ring. That's actually a good thing because it holds the space. This cortical material maintains the lens capsular bag so that I can place the secondary lens in the capsular bag. Now I use the 25 gauge vitrector after making an initial opening with the MVR blade, and I use that vitrector to make a new opening into the Sommering ring 360 degrees. At this point, without having to exit the eye, I turn the cutting port off, use the vitrector as an aspirator, and then remove all of this new reproliferated cortical material that has accumulated within the capsular bag. And I remove this, clean it so that it can receive the intraocular lens. At this point, I visualize my new anterior capsule opening, and I place the OVD in the capsular bag in such a way that it brings the new anterior capsule up to the iris. Here the OVD is being placed, and I think you can see with this close-up view in just a second, you can see the new anterior capsule opening. That allows me to use, here you can see the anterior capsule opening, new anterior capsulotomy, and now I can place the lens within the capsular bag where I would like it to be rather than in the ciliary sulcus, and that allows me to do secondary in the bag implantation. And this is what I do for almost all of the infants that I leave aphakic in early infancy. When placing an intraocular lens, and I start primarily placing the intraocular lens at just above 7 months of age, I use manual capsulorhexis, bimanual irrigation and aspiration, and I finish with my posterior capsule opening through the pars plana. This is my technique that I think I have the most control It's okay to use other techniques. This is my favorite. I'm also, of course, as probably many of you are who do pediatric cataract surgery, I'm doing more lenses in older children with a primary posterior capsulorhexis, pushing the vitreous face back with OVD, and then placing the lens within the capsular bag. My pars plana technique is my preferred technique for the younger children, but as the children get older, if I don't think they're appropriate for a YAG laser, then this technique, with or without capsular optic capture, is appropriate. My favorite technique with lens subluxation, with ectopia lentis. The patients I see usually have Marfan syndrome or some other type of progressive lens subluxation. I place both instruments within the capsular bag, aspirate the lens contents, and then turn on the cutter without ever having to leave the eye and remove the capsular bag completely. Then I bring the pupil down, and I have been very happy with the performance over quite a long period of time now of the Artisan Iris Claw lens for these children. I think it performs so much better than traditional angle-supported anterior chamber lenses. And so this really is my preferred technique, and we have now 6 to 7 years of follow-up with many of our children. Since we started using this technique, we gained access to it through the FDA. Now, I know in adult surgery for patients without capsular support that you are now becoming a little bit more accustomed to using other non-sutured IOL techniques, such as the Imani technique. And this is a case with not enough iris to support an Artisan lens, where I did use the Imani technique, and it did well. But this is only when the patient doesn't qualify, in my view, for the Artisan aphakia lens. I'm doing much more of IOL exchanges, and that's because in young children, we often leave an insufficient amount of hyperopia, and so they develop high myopia from the expected myopic shift. These cases can be difficult, and I think I've learned to manipulate these lenses out of the capsular bag. There is a lot of fibrosis in these kids, but preserving the capsular bag is paramount. I remove these lenses out of the capsular bag, and in this case, I was able to place the new lens back into the maintained but somewhat fibrotic capsular bag. And again, out of necessity, we're gaining more and more experience with safely removing these lenses from the capsular bag and placing new lenses either in the ciliary sulcus with optic capture, with or without optic capture, or back in the capsular bag, as this surgery demonstrates. Now, I also wanted to make a comment about these new, I call them physician-directed medications, rather than relying on the compliance of parents. Now, I operate on children, and the parents have to get the drops in. So anything we can do, anything we can place either intracamerally or here within the lacrimal puncta, is an advantage to us. And this is a dexamethasone insert being placed in a young child's puncta after surgery, and it will release the drug on a taper that is defined. It releases drug even when the child's asleep. And I find this to be an advantage. Our early results of using this device have been published, and we are now in the midst of an FDA United States trial to gain full approval for this device in children. I also wanted to make a comment about intracameral antibiotics. I would not do a pediatric cataract surgery without intracameral antibiotics. I think that many of us in pediatric cataract surgery were early adopters of this, and regardless of your antibiotic of choice, I think you should use it in children. We are often in the vitreous, we're higher risk, and I use intracameral moxifloxacin because it doesn't need to be diluted, and that's been my my antibiotic of choice. This recent article from 2020 emphasizes the safety of intracameral moxifloxacin, and they find in children that it is as safe as subconjunctival in children. Now, my many thanks for being a small part of this meeting. I wish I could be there in person, but I certainly appreciate being a part of the program. Thank you.